Good morning, good afternoon, good evening to everyone. Welcome to this second 2023 webinar of the European Society of Microbacteriology. My name is Elisa Tagliani and I'm a research scientist at the Emerging Material Pathogen Unit at the San Raffaele Scientific Institute. Today is a very special day. Today is World TB Day. And so this is really a message of hope for cooperation among all the stakeholders to achieve the Millennium Development Goal for TB, but for ending TB by 2030. So this is really a call to contribute to this goal. It's really my pleasure to introduce today's speaker, Dr. Daniela Maria Cirillo. She doesn't need a very long introduction. Everybody knows her, but just to say that she's a clinical microbiologist and she's the head of the Emerging Material Pathogen Unit here at the San Raffaele Scientific Institute, director of the WHO Collaborating Center, and president of the ESM itself. So Daniela has a lot of interest in many different fields, from development and research of new diagnostics, particularly for drug-resistant TB, studying the pathogenesis of the Mycobacterium tuberculosis, but also the virulence marker, host-pathogen interaction, NTM, and going to nosocomial pathogens. So really a lot. Before we start, I'd like to give just few housekeeping notes. So first of all, if you have any question, please type it into the chat, like chat windows. And at the end of Daniela's presentation, I will take care of asking all of your questions to her. You just use the live chat and you'll need to sign into YouTube and then join the channel. So just to remind that the live chat messages are not private, so everyone who tunes can read them. When you ask your question, please include your affiliation. And if by chance we are not able to address all your questions, I'll make sure that Daniela reply to you by email. Just send them to the email address of the society. And last but not least, please note that this webinar is supported by BD, but also that BD doesn't have a role or influence on the content of this presentation. And now, without any further ado, I'll pass the floor to Daniela. Thank you very much.
Thank you very much, Elisa. It's a pleasure to be with you on the TB Day. It's really a real pleasure to talk about a topic that may give a little, like 1 cent contribution to ending the epidemic of tuberculosis. So the topic for today's seminar is, should isoniazid testing become a priority? Is it important to test for isoniazid together with rifampicin for the management of tuberculosis? Let me start by introducing the problem. The problem is that isoniazid is a drug that is really relevant for the treatment of tuberculosis. Isoniazid remains the most potent early bactericidal drugs. Isoniazid has the capacity to pass the blood-brain barrier, as seen from the several reports from patients with tuberculosis meningitis that comparing outcome from patients with the disease caused by isoniazid-resistant strains versus isoniazid-sensitive strains. And the outcome is worse if the meningitis is caused by isoniazid-resistant strains. Rarely causes adverse event, so since the beginning is a pretty good drug, to be used in terms of toxicity and in terms of tolerance by the patients. Proven resistance affects both the preventive therapy and the treatment disease. As you know, the contact of patients with tuberculosis are treated with regimens that include isoniazid and rifampicin or rifapentin. And if the use of isoniazid in people that are contact of isoniazid-resistant TB cases are unlikely to benefit from isoniazid preventive therapy. The same can be said for the role of isoniazid preventive therapy in HIV-associated TB. In addition, isoniazid monoresistant is associated with the reduced probability of a successful treatment outcomes for individuals receiving standard treatment. In terms of epidemiology, if we do have almost 500,000 of rifampicin-resistant MDR-TB per year, we know that from the estimate of collected from survey run before 2017, we know that we have at least 1 million of cases that have resistant to isoniazid without concurrent rifampicin resistant. And this is a huge number, is almost the double or more than the case that are confirmed with rifampicin resistance. What is the definition? We will refer today at cases that are caused by Mycobacterium tuberculosis strains with resistance to isoniazid and susceptible to rifampicin, and those data are confirmed by either PCR or in vitro. If we look at the genes that are causing drug resistance, it's not moving. Why is not moving? Sorry, I do have a problem. No, it's fine. You can see that even in the most recent data showed that we have almost 3 genes that are really relevant and give the majority of the cases of resistance to isoniazid. With CAT-G and INH FRG1, CAT-G definitely being the leader, followed by the other genes that are contributed, are still contributed for 10–15%, depending on the epidemiology. The resistance to isoniazid has really an heterogeneous phenotype. The level of resistance can be predicted by the pattern of mutation. INH promoter confers only modest MIC increases and can be classified as sensitive if the phenotypic DST is performed on liquid media with using the current critical concentration. CAT-G S315 mutations correlate with a marked MIC increases. The combination of the two really gives the higher level of resistance. If we are using, as you can see in this graph, if we are using the standard concentration of 0.1 and 0.4 that comes with the commercial testing of isoniazid in vitro in liquid culture, what we see is that not even the higher concentration is able to discriminate the mutants that are conferring low-level resistance from the mutants that instead conferring only the low-level resistance. So whatever is added in terms of mutation to INH promoter mutation or CAT-G gene mutation can only increase the level of the MIC. So we do not have established a clinical breakpoint for isoniazid so far, but what is proposed for the test in midget is definitely not sufficient to discriminate the population that may respond to higher dose of the drug from the population that may not respond to the drug. In terms of history, few words. The history of TB treatment really started in 1943 with the use of streptomycin to treat tuberculosis. In 1951, we have the isoniazid coming on the market and opening the modern era of the treatment. The drug was inexpensive, well tolerated, and safe. Isoniazid has had also a funny story, because in 1951, it was an amazing coincidence when three pharmaceutical big companies launched almost simultaneously the discovery of the isoniazid, but was even at that time it was called isonicotinic hydroside, and then was renamed isoniazid, and this is the name we are still using. The drug was 10 times more potent than any other drugs used for tuberculosis. In reality, the drug was never patented. That also contributed to the low cost. It was never patented because it was described in a published report years before the pharmaceutical company announced to the world the discovery and the possibility to use of the drug. By the time that isoniazid became available, attention had turned on how the drug needed to be protected. So at that time, it was proposed in combination with streptomycin and PAS. And that became the first standard triple therapy for tuberculosis and stayed for the next 15 years until in the middle of the 60s, rifampicin was discovered in Italy. And from the end of the 90s, we moved from a triple therapy, including rifampicin, with the direct observed therapy short course that has been the biggest health breakthrough of the decade. That is the therapy that we are still using for drug-sensitive tuberculosis. As soon as the activity of isoniazid was published, immediately the reports of resistant strain became public. Isoniazid is a prodrug, is activated by the catalase peroxidase CAT-G, and the resulting active species reacts with NAD to form an isoniazid NAD compound, which inhibits the enoyl ACP reductase INHA, leading to mucolic acid biosynthesis inhibition and mycobacterial cell death. As I mentioned before, the major mechanisms of resistance are linked to mutation in CAT-G that encodes the activator for isoniazid. One specific variant, the S315T, is found in the high majority of isoniazid-resistant isolate. The second mechanism is a mutation in a promoter region of INHA, the C-15T, which results in INHA overexpression and leads to the titration of the drug. There are other mechanisms that are involved, but are way less represented And so those are really the major mechanisms that are targeted by the existing test. Let's now move to the data, the epidemiology and the outcome of the drug, the strains that are resistant to isoniazid. This is a cartoon showing the isoniazid resistant in new cases and previously treated cases. What you see colored in green, with all the shade of the green, is the incidence of the cases in the country that went either reporting surveillance data or data coming from drug resistance survey run by the WHO. As you can see, isoniazid resistance is a global problem that affects new cases and previously treated. The overall rate of drug resistance is about 11%, but we do have countries where drug resistance to isoniazid is a major problem. We do have recent reports that come from the literature, and among those, we do have a report from Vietnam where isoniazid resistance is a super serious problem, reaching almost a 20% prevalence. And the resistant is linked in the high majority of cases to CAT-G and mutation in FABG1. We also have data from Africa, such as prevalence of drug resistance in Zambia. Those are recent data showing a proportion of isoniazid monoresistant cases close to 10%, or data from South Korea, in which, again, the isoniazid monoresistance is an important part of the drug resistance to anti-tubercular drug. We also have unpublished data from big countries such as Brazil, where data collected from the region of Bahia or Rio de Janeiro or Amazonia are showing a high prevalence and very poor outcome for drug-resistant TB cases. So having data from drug resistance poses a second very important question. What is the outcome of people that are infected and developed a disease from a TB strain that is isoniazid resistant? We do have data from a systematic view from Medea Jaja, published in 2017, that put together data from 19 cohort studies plus 33 trials, including almost 4,000 isoniazid-resistant TB, and as a control, almost 20,000 drug-sensitive TB. The pool rate of failure and relapse for isoniazid-resistant TB were 15%, compared to the 4% of the drug-sensitive TB. It was also shown that there was a higher level of acquired drug resistance with all drug regimen in strains that were in people that were treated for a TB caused by an INH resistant strain. The conclusion was that the treatment of isoniazid-resistant tuberculosis with a simple first-line standard regimen resulted in suboptimal outcomes, supporting the needs for a regimen implementation. Standardized empirical treatment of new cases could be contributing substantially to the multi-drug resistant epidemic, particularly in settings where the prevalence of isoniazid was already high. not everybody agreed on the impact of isoniazid resistance on outcome of first-line rifampicin through the regimen, because it came clear that part of those cases, especially in some settings, could have been linked to a mutation causing low-level resistance to rifampicin, and those mutations were not picked up by the phenotypic test if conducted in liquid media. So in this paper that came out in 2020, there was a clear analysis of more than 7,000 episodes with known initial isoniazid and rifampicin status from individual patient database. And what was compared the outcome in those that turn out to have initial resistance to isoniazid and an underlying mutation that could have caused resistance to rifampicin that couldn't be picked up at the time of diagnosis, because the test used for diagnosis, that was mainly the expert, was not able to detect this low-level resistant mutation. So the claim of the paper that has some important arguments is that the part of the level of isoniazid resistance that had clinical failure could be attributed to underlying mutation to rifampicin. So those cases were not really isoniazid resistant only, but they were two MDR cases. And this is a point that is really important, because if we consider that the next guidelines for isoniazid resistant cases were considering the use of fluoroquinolones, it became very clear that treating with fluoroquinolones people that may have had true MDR could have led to the development of a pre-XDR phenotype. So testing and correct testing is fundamental to reach the diagnosis, to establish, to classify the case and move on with the correct treatment. Is it true that starting with the wrong test can allow to amplify unnoticed resistance? It is true, and what happened and may still be happening in Eswatini is just an example of how one test can lead in a particular setting to a selection of a quite dangerous clone. The use of expert XDR. The use of expert ultra or MTB-RIF in Eswatini led to the selection of one rifampicin resistant clone that actually was also MDR because it was isoniazid resistant as well, that went completely unnoticed and became the predominant leading force for MDR-TB in this small country. How that could have happened? Very simply, if you have a test that you are using to screen for rifampicin-resistant tuberculosis, and rifampicin-resistant tuberculosis is your proxy for MDR, as it is in many, many settings, and your test is not able to pick up one of the mutations that leads to the low resistance to rifampicin, these clones goes undetected. Then if your strategy is to test everyone in vitro and have a first-line phenotypic DST, then you may find out that this clone is resistant to isoniazid when you do the phenotypic test. But if you don't do that and you are just focusing on the MDR for further testing, you will be missing completely this clone. And this is more or less what happened. On top of that, this clone is also associated to a mutation that may lead to low-level resistance to bedaquiline. And so it's a particular threat for that setting. But as I said, this is an extreme case in which, in a particular epidemiological situation, a wrong test done at the beginning has led to the expansion of this clone. In reality, there was the need to look carefully into alternative treatment for isoniazid-resistant tuberculosis became very clear. So in 2018, an individual patient's data meta-analysis was published, and data were requested for several cohort studies and randomized trials. And what was shown was that the addition of fluoroquinolones instead of isoniazid increased treatment success, but didn't have significant effect on mortality or acquired rifampicin resistance. So the conclusion of this important publication, meta-analysis, was that in patients with isoniazid-resistant tuberculosis, compared with treatment with at least 6 months of what was the regimen proposed at that time, so rifampicin, ethambutol, and pyrazinamide, the addition of a fluoroquinolone was associated with better treatment success, where addition of streptomycin was associated with less treatment success. However, the quality of evidence was very low. Putting all this data together, the WHO convened expert group meeting to discuss the evidence and come up with WHO guidelines for the treatment of isoniazid-resistant tuberculosis, and that was done in 2018. Several intervention and comparators were analyzed, and the conclusion were that the 6 months regimen with rifampicin, ethambutol, pyrazinamide could indeed result in high level of treatment success in isoniazid-resistant TB patients. Addition of fluoroquinolones to those regimen, in this case, appeared to lower the risk of death and the acquisition of rifampicin resistance. In addition, it may increase the likelihood of success even when pyrazinamide is only used for 4 months or less, which could reduce the risk of hepatotoxicity associated to the long-term use of pyrazinamide. In this meeting, the category 2 regimen with a longer use of streptomycin was definitely killed, with the statement that the use of streptomycin was not associated with improved outcome. So the WHO recommended regimen became rifampicin, pyrazinamide, and ethambutol plus levofloxacin for 6 months. Now, what are the implications of such recommendation? So 6 months, we have said that 6 months of regimen plus a fluoroquinolone with pyrazinamide used for less than 6 months had advantages in terms of successful outcomes, but it was clear from the very beginning that that could have clinical and programmatic implications. And the programmatic implications were mainly two. The first one is that when do you need to shift to such a regimen? So do you need to know at the very beginning if someone is isoniazid resistant? And because you are adding a fluoroquinolone to a basically first-line regimen, do you need to know if the strain is resistant to fluoroquinolones, especially in those settings where you have a large amount of consumption uncontrolled of antibiotics for other reasons, that is leading to an increase of fluoroquinolone resistance also in MTB. So among the 3 pillars of the WHO strategy, one pillar is really, and the key component is really targeting the early diagnosis of TB, including universal drug susceptibility testing. The universal drug susceptibility testing is really still really not reaching its target, even if we consider as coverage, DST coverage, just the use of an expert in many cases. In this case, we need to move one step forward. Let me go one step back and pull and show you one of my historical slides from the Sondolo course in 2009. The LPA was just revised by the WHO, and the expert committee considers that there is a sufficient evidence to justify the recommendation for the use of line probe assay for rapid screening of MDR-TB in country-specific settings. Already, we were screening targeted group because we didn't have the possibility to use this test for all cases of TB. Immediately after, or more or less in the same, during the same training, I was showing this picture, talking about this magnificent, all-automated coffee machine for TB diagnosis that was going to come out. It was not out. It was said that will come presented to the world on the April 15th of the 2009. The WHO has approved the expert in 2010 and now has approved many other molecular tests to perform the diagnosis of TB and drug-resistant TB. Those tests have different characteristics, but the big push was to use the expert that it detects TB with a high sensitivity, in particular the ultra, and rifampicin resistance. Doesn't tell us anything about the isoniazid status. If this is the algorithm, of course, isoniazid goes undetected until either some other test is done, most likely not molecular, but phenotypic, but it will be kind of gap before we have those data available, or it goes undetected completely in the case that the strain is not rifampicin resistant, because in most settings, those strains don't go under phenotypic DST. Now we do have more tests. We do have also centralized platform that allow in most of the cases, or sequential tests that allow to test rifampicin and isoniazid. So the point is, if we really want to solve the problem of isoniazid resistance, we really need to change our approach, and we need to decide when is the case to test. Should we wait for early sign of failing treatment? Should we allow contact of those people to be treated with preventive therapy when isoniazid is not working for those? Those are main questions, because they do have a programmatic and economic implication. The in silico evaluation of the WHO endorsed molecular test shows us that even if the sensitivity doesn't reach 100%, while the specificity is usually almost 100%, when we look at isoniazid, we are in the range of 90% in sensitivity. And with all the tests that are now endorsed by the WHO. And if we look at the clinical performance has also a sensitivity that is pretty high for all the platforms that were considered, and the performance can also change from different settings, because in the unlikely and unlucky case that you have a strain that bears a mutation that is not picked up by one of those tests and become epidemic, then of course your parameters will drop. But those are extreme cases that should be monitored in other way. Do we have WGS? Yes. Before we consider WGS and in particular targeted NGS for isoniazid detection, it's probably going to be a long run. But definitely if this is performed from direct samples, sputum sample that are smear positive, and is performed with a platform that is pretty rapid, such as the Oxford Nanopore, and the reading is done online simultaneously during the run, we will be able to pick up in a real short time the mutation that are leading resistance to isoniazid, together with all the mutation that can give us a almost complete picture of the profile of the strain based on the data that we know now. Now, is it relevant to look for the mechanism, or we just needed to have a yes/no resistant answer? It is probably relevant because Khaliduli has recently published a paper in which she says that for mutations that are leading to low-level resistance, increasing the dose of isoniazid could still consider the drug as effective for the treatment of those people. Do we have example that isoniazid resistance is really, and that early detection can improve tuberculosis treatment? Yes, we do. We have a couple of studies from different settings, one from France, in which data show that the molecular detection of isoniazid resistance on an initial sample was independently associated with an earlier treatment adaptation. All samples that were smear positive were evaluated by an LPA and the samples, and the treatment was changed immediately after the answer was available. Different opinion from the impact at the population level of isoniazid testing. I'll show you two different publications that may look like leading to different conclusions. They do lead to different conclusions, but they are really examining different aspects. The first one from Claudia Denkinger, Madhu Pai, David Dowdy, they look with modeling. Those are modeling study that was performed using India as a model. And the conclusion were that when added to a rapid test for TB plus RIF resistance, detection to INH resistance has a minimal impact on transmission of TB and isoniazid monoresistant TB. But again, this is impact on transmission when added to an algorithm that is detecting TB plus rifampicin resistance in India. A different conclusion is reached by this always modeling study led by the Canadian group, Dick Menzies, and the conclusion were that accurate diagnosis and tailored treatment of INH-resistant TB with LPA led to an almost 50% relative decrease in acquired MDR-TB when compared with an expert MTB-RIF strategy. So the measure they were doing, the outcome they were measuring is different. One study was looking at the transmission of INH-resistant TB. The other was on the impact in the acquired MDR-TB by testing upfront for isoniazid resistance. So avoiding starting a treatment that would have led into a rifampicin in monotherapy for 4 months in patients where isoniazid resistance was ignored. The conclusion was that continued reliance on diagnostic and treatment protocol, ignoring isoniazid resistance, will likely result in increasing the MDR-TB. I will conclude now with this statement. That paper came in 2020 from Madhu Pai and Georgia Soulis, and it was addressing as a commentary the isoniazid-resistant tuberculosis, a problem that we cannot longer ignore. So is now the time to find the best strategy to invest money in solution that will allow us to target, together with rifampicin resistance, isoniazid resistance. Of course, until the regimen we are using for treating drug-sensitive tuberculosis remains the regimen that was started in 1974 under the DOTS strategy. Now the question is for you, how to do it? Who should be prioritized? Is it ethical to offer isoniazid preventive therapy when we think that the index case could have TB isoniazid resistance? Should we focus in the technologies that can give you a combo? Should we centralize, move to the periphery? How much in terms of resources is needed to move rapidly into implementation phase for drug-resistant treatment? I will stop here. I need to remember you that we will have the ESM course, in Tirana, ESM annual meeting in Tirana, Albania, at the end of June. It's going to be a fantastic meeting. We have excellent speakers coming from all over the world. You still have time to submit abstracts, and also for the young people under 40 to apply for the Gertrude Meissner Award. The deadline is at the end of April. With that, I need to thank all my collaborators. I wouldn't do anything without them. Elisa knows that very well. The funders, and then remind you that we are still in the TB day, and all together we can end TB. Elisa, the floor is yours.
Thank you. Thank you very much, Daniela, for this very, very clear presentation. We do have some questions from the audience. The first one from Marco is related on the establishment of a clinical breakpoint. So he's asking whether for phenotypic drug susceptibility testing, it would be feasible using a concentration of 4 or 8 as a high dose for isoniazid testing. And that will give us a clue on whether high dose the regimen containing high dose isoniazid at 10 or 15 mg per kilogram would work.
Probably, if I can go back to that slide, I don't know if I can. Am I still sharing the screen or no? Hello? Oh,
You're not sharing.
Okay, okay, but it doesn't matter. It's too complicated now. And so, I mean, if we want just to consider the distribution of INH promoter mutation, probably a concentration of 1 could be taking the majority of them. The concentration of 1, between 0.5 and 1, you start seeing an overlapping between strains with some strains with CAT-G, some of them non-315, that could still probably be treatable. If we want to take also all of them out, probably between 2 and 4 is the right concentration, is the right critical concentration to be used. So far, my point is, if you want to test a 0.1, then you take the wild type population and the mutated population, and you divide those. If you are at this point looking at the distribution, at the specific mutation, this is probably also a very good proxy. So you may not need to test at a second concentration. So if you give the priority to the molecular test, you may be able almost to have the same answer. I don't know if that answers your questions. Somehow I lost you.
Yes, thank you. I want to go back to one of the questions that you discussed on your last slide. And well, the diagnostic pipeline is rapidly developing, and as you said, few new molecular tests that could be used at the point of care or near point of care will soon come out to test for isoniazid resistance. But today, the only one that can be done at more peripheral level is the expert XDR test. So what
the problem, Elisa, there is a pragmatic and logistic problem. The expert XDR platform, and I agree with that, will be installed at the MDR center and the PMDT center, right? So moving, and those could be decentralized, but the test is mainly focused on picking up the fluoroquinolone resistance in MDR in addition, and will be a follow-on test of rifampicin resistance. So far, how the diagnostic algorithm is structured right now, you need to have a referral of people that are failing the first line therapy. They have an early sign of failing, and those be transferred. I don't see how we could substitute unless in countries where there is an important point. I mean, the important point is that we are talking about an average of 11% of isoniazid resistance overall. But we do have countries with more than 20, and we do have countries with 3%. So we need really to have the country-specific data in order to understand where it is crucial to move as soon as possible in this direction, and in countries where the system could really keep working the way it is. I hope in the future we will have platform able to do both. There is also an issue of cost, that 1 + 1 makes 2, also in terms of cost. So if you want to spend $10, you don't have the money to spend 20 for all in all the cases. We are still struggling in implementing the molecular diagnostic for TB instead of smear microscopy in some settings. I don't know if that answers your question. We needed to have something more adaptable to the periphery than the expert XTR. We may need to have a reflex test for TB. Consider that if you use that as a first test, you are, in case you have a test that costs you more, but you do more, but it gives you the 3 targets with TB, rifampicin, isoniazid. You are going to use this test that could be more expensive than one that does only 1 or 2 for everybody, you know, all the people that need to be screened for TB. This is a huge number. You may consider a reflex, an easy to use reflex test using the same material. What needs to be avoided is the second specimen. You know, the request for a second specimen may really complicate. So ideally, either you have the same cost, or you have one test that costs less than what we have now. It gives you TB, yes or not. Then if it's TB, then you have a panel of molecular determinants that allow you to start first line treatment tailored for the profile of drug resistance. If it's MDR, then you need to do more, because then you need more complex tests targeting the main drugs used for MDR right now.
Thank you. Then we have a question from Rickettsia, and she's asking whether the molecular results assessed the level of resistance to isoniazid, or still phenotypic DST needs to be done to better inform.
The pattern of mutation can give you the level of, can be associated to the level of resistance in the high majority of cases, definitely in the most common determinants of drug resistance. So you do not need to do phenotypic testing.
Okay. We do have another question, but it's not, it's more related to the use of the expert MTB RIF and ultra test, so it's slightly out of topic, but it relates to the use of the expert MTB RIF on extrapulmonary samples. And
you can use the expert MTB RIF in an extrapulmonary sample. It is a problem in Europe because it's not part of the IFU. I don't know from where you are, but so in Italy, it is a problem because you are using a test off-label. The WHO includes the test, the use of expert in extrapulmonary samples. So can be done.
So another question is about the use of these centralized platforms that can simultaneously test rifampicin and isoniazid resistance. Mm-hmm. So this could certainly solve the problem in some settings, but then there are some implementation considerations that need to be done. And so according to you, what would be the best algorithm for using, or settings for using those platforms?
In settings where centralized tests, so settings where you can design an efficient sample transport in large urban conglomerate, and we have many. And then this kind of platform are able to perform a huge amount of work. There are settings in which the expert infinity was needed to be set up because the number of samples was huge. So in this kind of setting, the centralized test on a robotic platform or semi-robotic platform is definitely a possibility. You need to have, you really need to set up a good system for transporting the sample and reporting the results. Reporting the results, to be honest, with the needs to implement LIS and bioinformatic access and internet access doesn't seem the major problem. Transporting of sample is still a problem, but needs to be set up, not only for this. There is a high need to work out solution for sample transport.
Thank you, Daniela. And just to clarify that the question about the use of expert MTB RIF or ultra was from a person from Algeria. So I don't know if you...
No, I think in Algeria, you may not have such a restriction. Even outside, you rely on WHO guidelines, so you can do them.
Thank you. So
the performance is different depending on the samples that you are testing. On pleural fluid, is very poor, but it's not linked to the test. It's linked to the fact that you need to test a pleural biopsy, not a fluid, to make the diagnosis of pleural tuberculosis.
Thank you. So now I don't see any more questions from the audience. Do you have any, really 1 minute take-home message?
Well, my take-home message is to think about isoniazid resistance until collect data from your own setting and try to understand how big is the problem where you are working. And based on those, try to solve with the current assays. Until we have this regimen for drug-sensitive TB, isoniazid resistance cannot be ignored anymore. Thank you very much to everybody. Have a happy evening, afternoon, morning, wherever you are. Please celebrate the TB Day in your community, in your setting. And Elisa, back to you.
Thank you very much, Daniela. And I just join you in thanking the audience and you for the great presentation and discussion. Thank you very much to everyone.
Thank you all. Bye-bye.
Bye-bye.